puckered, you know, not looking like the other, then that is an indication that something could be wrong. So with breast cancer, the statistic is still correct. When I was your age, it was 1 in 10. 1 in 10 women. Now it's 1 in 8. Why do you think that statistic's changed? Because now it's even worse, isn't it? 1 in 10 is like, so 1 in every 10 women. Okay, now it's 1 in every 8. Why do you think that statistic changed?
The crap we're eating today.
We're getting more exams and we're catching them sooner. So there would be, so in that 1 in 10 statistic, there would be somebody that it wasn't caught. You know, it wasn't diagnosed. So we're getting much better with our imaging modalities. When I first moved out here to California, I did mammograms as a tech in Texas. I did mammograms. But coming out here, you had to have a separate license for that, okay? Back in Texas, I could do fluoro. But out here, you have to have a separate license for that. And so as somebody from the outside coming in, I was like, oh, do we have to have a license for hands? Do we have to have a license for elbows? Are we just going to go down the list and have all these different licenses? And I wasn't real thrilled about that. So as we go through this slide, I'm totally convinced we need licensing for mammography. You need to be properly trained, extensively trained, more than what I got. And I'll show you the reasons why, but we're so much better at our imaging than we were before this licensing. And I'll go over that. Second leading cause of cancer deaths, do you know what number 1 is? Lungs, yes, lung cancer. So that's the number 1, is it lung cancer? Yeah, lung cancer. Yeah. It's either that or heart attacks. Who did a report? Anybody do a report in here on mammography last semester? Okay, well, I've just lost it. Are you looking it up? Yes. Thank you. Men develop breast cancer also. Men, we usually find it very quickly. They usually find it very quickly because there's not much breast tissue there. So any lump or growth would be easily detected. However, gentlemen or ladies, guess what they don't do? Well, they probably don't do that, but and it's not necessary so much because if there is a tumor growing, they'll see it pretty quickly. But they won't go in. Oh, how long have you had that lump? Oh, about 3 or 4 months. Oh, dummy, you know. They don't go get it treated, so it can be a problem. So with mammography, we can detect lesions up to 2 millimeters, maybe even less than that. Okay. If a lesion has gotten up to 2 centimeters, and typically it has metastasized. So it's really important that we catch these tumors quickly. Although I did see another stat. There's lots of stats on this. I did see another stat that said if detected early, there's like a 80 to 90% cure rate. So that's why it's important to detect these tumors. And that a lot of tumors, and it's the research I've said, what happens when a woman finds a tumor? Not to panic, that a lot of tumors are not necessarily cancerous. Okay, so the MQSA, this is the Mammography Quality Standards Act. MQSA in 1994 came about, and this is when I was like, oh, really, we're doing another licensing. This is where the equipment design and operating standards came about, and we had to have a dedicated mammography unit. Now, this was nothing really new. However, prior to having dedicated units, they used the X-ray. Can you imagine? So you can imagine the quality was not very good. But as far as, I mean, ever since I've been in the profession, again in the dark ages, we had a dedicated unit. And then this quality control program, you know, we learned about QA, about our collimators, about our SID should be accurate, right? Remember those experiments we did last semester? We do the same thing with mammography, except the error of margin is much stricter. So for instance, when we did film processing for, you know, regular radiography, and they did film processing for mammography. You couldn't use the same processor. The one for mammography had much more stricter control over the temperature, chemical concentration, and that sort of thing. Now, if your regular processor met those standards, then you could put mammography film through it. So that's just an example. Did you find?
For cancer, it's lung.
Okay, so it is.
Twice as much as breast cancer.
Okay, lung cancer is twice as much as breast cancer. That's
Heart disease is #1 overall.
for overall. Okay. So heart attacks overall for everybody, but for women, first one is lung cancer, second is breast cancer, and apparently lung cancer is twice as much as breast cancer.
No, I'm sorry. For women, it's breast cancer is #1.
Oh,
But for both male and female,
it's lung.
lung cancer has the highest.
Oh, okay.
Yeah.
Thank you. Okay, so most of our, when you call for an appointment for a mammogram, they'll ask you if it's screening or diagnostic. A screening exam is just that you have no symptoms, you have, you know, nothing, it's just for a checkup. Okay, they haven't found anything wrong. A diagnostic exam is after a screening. So if you have a screening exam and they find something and you're coming back for further imaging, then that's a diagnostic image. Okay, so and ladies, it's very important, and if you've ever called for a mammogram, they ask you that. Is this a screening exam? Don't lie to them because they have the time and date you want. Because not all mammography clinics do diagnostic exams. They're equipped for regular checkups, but if you have anything more than that, they may not have somebody to do a biopsy. They may not have somebody who's qualified to get different types of images. So just something interesting I found out. So what is BSE? Breast self-exam. It's recommended that everybody do this once a month. And then this CBE is a clinical breast exam once a year. So everybody, what this means is we're going to learn how to do a breast self-exam on our phantoms. But if you have, let's see if I can draw it. Okay, so here's the nipple, here's the breast. When you do a BSC, it's recommended that you use the tips of your fingers, the pads, not your fingertips going down, but the pads of your fingers, 2 or 3. And you can, have you ever mowed a lawn? This is what I call the lawn mowing technique. When you mow the lawn, right, you're pushing a lawnmower, and then you go to make a turn. What do? Anybody ever? Yes. Don't you overlap a little bit? Or if you don't, you're going to have a little slight row of grass right between the turns. So that's the same thing for a breast self-exam. You don't want to miss any tissue. Any tissue that is missed could potentially have, you know, a tumor in it. And then everybody, the tail of the breast, here's the shoulder and arm. The tail of the breast goes up into the armpit area. Okay? So the breast tissue is not just here. There are lymph nodes and breast tissue up in this, we call this the tail, T-A-I-L, portion of the breast. Okay, so when you're doing the lawn mowing technique, going back and forth like this, don't forget this area too, okay? And again, look at pushing with the pads of the fingers. You're not, just like you do when you're palpating the iliac crest, can't you put more pressure when you're using, you know, a larger area than poking like that? Same thing, you're not going to feel anything poking at breast tissue like that. You feel, and you can press harder to feel deeper. So, you know, smaller breasts would be easier to do a BSE on. Larger breasts is going to take a little bit more time. So I have some phantoms, small, medium, and large, and there are tumors embedded in those phantoms. And let's see, we'll find out today how good you are at finding the tumors. And just, you know, it says monthly, why not weekly? BSE, this should be done every month. And when the female, especially, is not on her cycle, ladies, what happens when we're on a cycle, then our breasts swell up a little bit, and sore. And so we don't want to do a mammogram or a BSE during that time. So either before or after that time. And it should be somewhat consistent. But why monthly? Why not? I mean, this is so important. Why not every week? Why every month? Why not maybe 3 times a year? You want to do it far enough that you can feel a difference. If you think and you have to get to know your breast tissue. Because the first time I did that, I'm like, is that a lump? Is that a lump? I think that's a lump. Is that a lump? You know me, you're getting to know me. I have a pain in my chest. It's pleurisy. It can't be a pulled rib muscle. Or I'm having a heart attack and it's a pulled rib muscle. It's always worse than it is. So you have to get to know the breast tissue. And then a month later, well, I liken it to seeing a child you haven't seen in a long time. Okay, so you see the infant, you see him again, a year or 2 later, and you're like, oh my gosh, you've grown, right? Or you haven't seen him in a while. Wow. And the parents never see that because they see the child on a day-to-day basis. Oh, yeah, I guess they have grown. We're just doing our thing. So it's the same thing. When you're doing a BSE and you think you feel something, a month later, you can make that determination if it's changed, if it's grown or not. You're doing it often enough to where you're familiar with that tissue, but not so much later where it's like, oh, it was little, now it's big, now I can feel it. I tell you what, when you can start feeling those bigger lumps, you're in trouble at that point. So the BSE, along with the mammogram, yearly mammogram, is your defense against breast cancer. Okay, a CBE is when I go to the doctor once a year, or twice a year now, for a pap smear, and the doctor does this to my breast tissue. Well, not quite like that, but good enough. So do you think my doctor's going to remember my particular breast tissue a year later? And no. And so while as thorough as they can be, they're not as familiar. So I'm not saying to ignore that, but don't rely just on that. Okay, you need to try to do, and it doesn't have to be your own breast tissue, gentlemen. I mean, we could, have fun with this if you wanted to, make a game out of it.
Like, babe, it's been a month.
Hey, you know what? Let me tell you, when I was doing mammograms, and again, because you know me now, every time we caught cancer on a female patient, my first question was, what made you come in for this mammogram? And 9 times out of 10, somebody else felt the tumor. I'm just saying. So, anyway. So, now this has changed baseline by the age of 40. So, the chances, again, I think I've told you that before, you turn 40. Okay, statistics at 39 and a half are down here of anything happening to you. At 40, they go up here. Okay, so 40 is like the magic number. I just call it that. One doctor told me it starts going downhill from 40 on, and I'm like, oh, thank you. No, I'm not coming back here. I don't want to hear that. So, but it's true. So based on the age of 40, they're changing this. This is different now. They're recommending it at 50, and then after 50, every 2 years. Every year still at 50?
Oh, you think it's just that year?
Oh, well, age 40, 50, every 1 to 2 years, or after the age of 50 every year, and I think this is changing. I think this has changed to 50, and then after 50 is every 2 years, unless you feel something or something is different. That's between you and your doctor. Okay, that's between you and your doctor and maybe your insurance company. Insurance company drives this stuff. Insurance companies look at the statistics of women between the age of 40 and 50 having breast cancer versus over the age of 50. And so then it's recommended if there's not that many, whatever that statistic is. What if I'm one of those statistics? What if I'm in that group that, You know, so that's between you and your doctor, and maybe your family history, and personally what you're going through, and that's something for you and your doctor to discuss to figure out how often you want to have this done. I would say definitely by the age of 50 every year. There was a time when they thought that exam, the radiographic, the mammogram itself was causing the cancer. And I'm going to show you this, the difference between film screen. I'm sorry, what we had before was zero mammography, X-E-R-O, like Xerox company. Zero mammograms, used a lot of radiation. It's like I compare that to before even, I worked with it a little bit, but remember those cardboard cassettes that we worked, oh, you don't.
Well, you
showed it to us.
Okay.
We didn't use it.
Okay, that's right. See, I forget. We did a finger or a hand, and it was like 150 mass. And what I meant by a cardboard cassette, we didn't have screens. We didn't have the screen, so we just used direct radiation to image a hand, and it was 150 mass. What do you use for a hand x-ray now, mass-wise? One mass. Okay, so that was just the way it was with mammography. Using the zero mammography, it was paper that we used, and I'm not going to go into that, it's long gone, but the exposures were so high. And so they thought maybe, so that kind of contributed to some of the concerns about using radiation on the breast tissue. Now we're in digital mammography, doses are low, and quite different, and I'll show you some comparisons. So look, I'm not going to go over it too much, but a couple of things. Look at the breast anatomy. This inframammary crease is going to be important for imaging purposes. We want this fold right here to be open. Certainly larger breasts, this is just a picture, but a breast would hang down, and that would be closed. So on a mammogram, the breast tissue needs to be brought up and out to open that crease. Again, anything that's folded or superimposed can hide a possible tumor. So it's important that that area is open. Nipple in profile, if the nipple's tucked under, which it can be, that can look like a tumor. So the nipple needs to be brought out in profile. We are handling breast tissue during a mammogram. So you are manipulating the breast tissue and how it's going to be presented on the image receptor. There is the pectoral muscle, and then there's a retromammary space. A lot of times this is where they'll put the implants here. This muscle is going to be important for imaging purposes because when you see the muscle on the image, what does that tell you? You got all the breast tissue on there. If you don't see the muscle, then there's the question of whether you got all the breast tissue on there or not. There are different types of tissue in the breast, and it changes over the period of a female's life and whether they have had children or not. But the three types, we have adipose and glandular and connective. Glandular, fibrous, and adipose, so fatty. So here's some breast tissue. You can see the denser areas are the glandular or fibrous tissue. And usually this is, younger females tend to have a more glandular fibrous breast tissue. So you know what a tumor looks like on the breast image? Like this. It looks like this. This looks like a tumor. That looks like a tumor. Good thing I'm not reading this. Cancer tends to be what they call spiculated. So you might have the tumor itself, and then you have these tentacles. It's not a round, circumscribed structure. It's something that's round and has smooth borders that's typical or indicative of a benign tumor or maybe even a cyst. It's when the edges are striated, spiculated, star-like pattern. That's when we get a higher degree of concern. So it would be hard if there was something like that in here, and it would be white, just so you know, it would be white. So here looking at, all adipose tissue, and then a very dense breast. Maybe some women have that just naturally. You see this white triangle thing right here?
That's a muscle.
That's the muscle. Yes, that's the muscle. So when you see that, you know, and you see how the breast tissue comes up? So breast tissue is not just here, as I said, it comes up. So just keep that in mind. When we image breasts, we always, of course, get a patient history. And so you're going to ask the patient, you know, a series of questions, but certainly one of them is, you know, why are you here? Is this just a routine checkup? Did you feel anything? And so if they have felt something, or when you're looking at the breast tissue, if there's a mole, a scar, anything that might show up on the image, then that needs to be documented. So we let the radiologist know, probably written, in what quadrant we found that. So looking at upper outer quadrant, lower outer, upper inner, lower inner quadrant. Okay. We can also talk about the breast tissue in terms of a clock. Now this is what we use. This is a method we use in sonography when we're doing sonograms of the breast. We talk about it in clock hours. So we'll tell the radiologist this mass was seen, or this structure was seen at 1 o'clock, at 2 o'clock, or whatever, on whichever breast. So in radiography, we'll be using this method. And I don't know what you think, or if you ever thought about it, but I just thought there was one duct coming to the nipple, but it's actually several ducts coming to the nipple. And one of the things that you look at when you're doing a BSC is if there's any discharge from the nipple. Unless you're a lactating female, there shouldn't be any liquids coming out of the nipple. So if there is a discharge, that would be a concern.
So I know in radiology we're not supposed to say like, oh, like I see a mass in the lung, but for mammography we would actually report to the doctor, I see a mass at 1 o'clock.
Well, in ultrasound, we're the eyes of the radiologist. Okay. So we would not say, oh, there's a malignant tumor at 1 o'clock. We say this structure is seen at 1 o'clock, and we have to describe it sonographically as hyperechoic, with circumscribed borders, posterior enhancement, blah, blah, blah. We can say all that without saying it's a cyst. You know, you describe it without saying it's a cyst. And then, of course, when you work with a radiologist, they get to know you and stuff, and you just go, I see a cyst at 1 o'clock. And then here, I took pictures of it, and then they have to call it. That's the difference between ultrasound and radiography. I take the image and give the radiologist great images, and then they make the diagnosis from those images. With ultrasound, the radiologist only looks at what you give them. So if you miss that tumor, I have missed pathology. We all have. Try not to miss pathology, and if I don't image it, then the radiologist doesn't see it. I've imaged pathology and didn't put it down in my report, and the doctor's like, well, what is this? Oh, yeah, okay. And then I've made normal look pathologic. Thank you. Thank you very much. Again, early learning, you know, but we've all done it at one point or another. So it's very important in sonography that's why that level of anatomy and physiology is important, and being very thorough in your scanning. So it's tough. Okay, so general considerations, patient prep. So let's get the patient ready for this exam. Remember, this is when we taught you how to do chest x-rays, we said have the patient put the gown on with the opening in the back. You would think, oh, well, they should know that. They don't. A lot of females, not necessarily the males, and the males don't care if we don't care if the opening's in front or back. But for our female patients, especially our older ones, they're used to these mammograms once a year, and so that's how they put the gown on with the opening in front, so that one breast at a time can be imaged and the patient's still covered. We can't wear any deodorants, any perfumes, any powders, or anything like that. Those little flakes of deodorant, little flakes of powder or perfume can go onto the image receptor, and guess what? Cancer tends to have microcalcifications in it. So when you see when you see microcalcifications on a mammogram image, then that's a big concern. So we don't want any of those dust. Image receptors have to be cleaned, no dust, because it can show up. So that's why this is important. And then we take a history, number of pregnancies, histories of medication. Medications can cause the breast tissue to swell or be different. Any previous surgery, mammograms. They like, just like most things, especially chest x-rays, mammograms, the doctors like to see the previous mammogram. They're looking for changes. Just to see a mammogram, your diagnostic accuracy is not going to be as great unless you have something to compare it to. Okay, so it's, if they don't have that, then they don't have that, but this is great to have. And then, as I said before, is this diagnostic versus screening? And then, as I talked about before, if you notice any moles or scars, or if the patient has any of those things on their breast tissue, then you want to indicate that. All of this is given in a sheet to the patient. So they're given these instructions. So what is your job? They've been given the instructions, so you shouldn't have to go through this, but you got to make sure they follow the instructions. That's your job. Maybe your job is not to give them the instructions. Your job is to make sure they follow up, that you follow up, that they follow the instructions. So two-piece clothing, just again for convenience, they just take off the top and put on the gown. And as I said, no talcum powder deodorants. So again, trying to schedule the mammogram not during the menstrual cycle is important, where the breast is less tender. Caffeine can make the breast more tender. A lot of times women will have what they call cystic breast, or some women will have cysts in their breast, and that can be controlled by their diet. So we have learned that caffeine, anything with caffeine, coffee, chocolate, anything with caffeine in it, and you got to be careful if you're taking some aspirin has caffeine in it. So you'd be surprised at where you can find caffeine can make the cyst larger. Okay, so reducing that prior to sometimes will help. The other thing too, when palpating breasts, doing a BSC and you feel a lump, pushing on it, if it hurts, it tends to be a cyst versus a tumor. So not 100%, but just something to think about, when you're in that panic situation. Does that hurt? Then a lot of times. So if a woman has cystic type breast or has a cyst in her breast, that compression will hurt more than otherwise. So reducing the caffeine intake prior to would help that particular patient. If you had the prior mammogram, so maybe I try to go to the same place each time. Now, throughout my history of breast mammograms on myself, I've gone to different places, but it's best if you like the place and you feel comfortable with your tech, is to try to stay in that same place so that you have that consistency of previous mammograms. If not, you just have to have them sent over from another. Breast implants. We are so much better at imaging breast implants, and we're not imaging the breast implant. We're trying to image the breast tissue hidden by the breast implant. And so we're much better at that now than we've ever been before. We have certain techniques, and I'll show you that. We try to, literally, we manipulate the implant up the chest wall to get it out of the way so we can just look at the breast tissue. So I had one student, bless her heart, this is